Welcome to the No Plateau Podcast for stroke and brain injury survivors, their caregivers, and the therapists helping them to break boundaries in their recovery journey. Hosted by Henry Hoffman, occupational and clinical therapist, this podcast is intended to supplement stroke and brain injury survivors' recovery journey. Therefore, all content affiliated with this podcast is for informational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. And now, here's Henry Hoffman.
Hello, everyone. Welcome to today's clinical podcast discussing a hot topic surrounding OT schools and evidence-based learning. Today, we'll touch on the educator's role in translating evidence to practice. What challenges currently exist? Where are the pitfalls? And how do we improve? Do we even need to improve? More specifically, how prepared are the new grads when it comes to implementing best practices in the field of neurorehab? I am your host, Henry Hoffman. I'm thrilled to be with you today. The talk today will be super helpful not only for current clinicians, but students and new grads. It is important that we bring you topics that challenge the status quo and force us to sometimes have uncomfortable conversations to get to the bottom line. To help me discuss today's exciting topic, I invited an occupational therapist, Jessica Schmidt. Jessica is an assistant professor of occupational therapy at Concordia University of Wisconsin. She earned her master's from the University of Wisconsin-Milwaukee and her post-professional doctorate in occupational therapy from Rocky Mountain University School of Health Professions. She's a member of ACRM, AOTA, and WOTA. In clinical practice, Jessica specialized in treating adult neuro patients in acute care and inpatient rehab settings. She is passionate about evidence-based practice, helping translate research into the clinic, and preventing healthcare worker burnout, which I can't wait. Maybe, Jessica, you can help me with my burnout that I have on an hourly basis. Welcome. How are you doing?
I'm good. Thank you for having me on the podcast.
Well, thank you for being on the podcast. We're really, really excited to have you. How about we start off with you expanding more about your personal and professional background? This group that is listening today are obviously a mix of clinicians. Actually, we have some patients as well, but it's a mix of clinicians, OT and PT, and some of them are also students. So if you could just expand on your background, that'd be great.
Yeah, so I have been an occupational therapist for 12, going on 13 years. I practice in inpatient rehab hospitals. I practiced at a level 1 trauma hospital and really focused on neuro rehab and treating stroke patients, spinal cord injury patients, and brain injury patients. And so I have been in the academic setting for going on 4 years now and really just want to help get our patients the absolute best care they possibly can by teaching my students the absolute best and latest in practice and hoping to really help change the way we're practicing.
Absolutely. Absolutely. Well, thank you for sharing that. And we're excited, to have this awesome topic. But let me start off with this. Nearly everyone agrees that evidence-based practice is essential in anything we do. Evidence-based practice should, quote unquote, have broad support among professional health organizations, insurers, healthcare administrators, faculty, OTs, right? So I did do a little bit of research prior to the podcast, and according to one study, a staggering 97% of OTs agree that evidence-based practice is necessary to practice, while 92% say it helps in decision-making. And then a similar survey of Swedish occupational therapists found that 95% acknowledge the benefit of research-based practice guidelines. An even greater number, 99%, conceded that guidelines are important so patients can receive equal treatment. Just wanted to set the stage and state the obvious, hopefully. Now I know we are going to touch on guidelines and knowledge translation, so why don't we just dive in if that sounds good to you? And if we could start with explaining to us what exactly is knowledge translation.
Yeah, so knowledge translation has been defined as the process that includes synthesis, dissemination, exchange, and ethically sound application of knowledge to improve and provide effective health services and products and strengthen our healthcare system. But in more lay terms, that is really how do we get research into practice? How do we narrow that gap between research and clinical use of the research to really improve healthcare?
Okay, got it. So, how long does it currently take? A common phrase is called bench to bedside timeline. They, deep in the laboratory, you're learning about certain solutions that are proven to be effective, but it takes a long time, I'm assuming. to get me and you out in the clinic, let's say, actually doing it. So how long does it currently take for research to be implemented into practice?
So some research findings have suggested that it takes about 17 years for research to become standard practice within a healthcare setting. There are some estimates that vary, but usually somewhere between 10 and 20 years, which is a really long time. As a health community, we really need to prioritize decreasing that time frame to really best serve our patients.
Okay. Well, yeah, that makes sense. And I know we're going to definitely want to dive into that. But let's just take a step back and just kind of talk about knowledge translation. What are the steps that are needed to translate this evidence? And what does that process typically look like?
Yeah. So first, new knowledge is generated. So researchers are going to investigate the effectiveness of existing or novel new treatments and compare the effectiveness to what is currently being done or maybe to no treatment at all. And then they're going to take that information and synthesize it, put it into research articles, present it at conferences, and then really need to identify best practices once more than one research study has been done. That's done through things like systematic reviews and meta-analysis. And then we really need to take all of this knowledge that we have and disseminate it and get it into clinical practice. So traditionally, researchers would write articles, present their findings at conferences. Clinical practice guidelines are another way that we're trying to get and disseminate that information into clinics and help clinicians really uptake the new information.
Yeah, that makes sense. I wish it was a little faster. I mean, that 17 years seems like a long time, but I get it. How do you actually narrow that gap between what they're doing in the research labs and universities and then getting it to clinical use from your perspective?
So one thing that we really need to do is find better ways to get the information to clinicians. We know that the gap is really getting the information to clinicians, not getting more information. So we know that clinicians typically report not having enough time to read research or not feeling like they have their confidence in their abilities to interpret the research. And there's a whole topic of research trying to figure out how do we best translate that knowledge into practice.
Right. Well, why don't we dive into actually some of those barriers exist when you're trying to take the evidence into knowledge translation from your perspective? What are some of those barriers?
So I already talked about just having enough time to read the articles. We talked about clinicians don't always have time to attend the conferences where lots of information is being put out, or maybe they can go to one conference a year. And then another barrier is lack of support in the clinic. It takes resources, it takes time to be able to have education to learn how to do new interventions. And it also takes equipment and really just being able to change habits of how people practice is another barrier.
Yeah. I would definitely imagine that being part of it. And I know we're both, neuro leaning. So we'll dive into neuro rehab limitations later as we go through this. But when I think about the factors that help implement evidence-based practice, I'm picturing this interconnected web of systems and health professionals that play a role to translate knowledge into practice. If you can just spend a minute identifying, and I'll think about the same, who are these critical players or systems that are interwoven, if you will, that's really responsible? Who's all involved to actually help implement this evidence-based practice from your perspective?
Yeah, so researchers need to be involved. We know that when researchers actually are in clinics, that uptake increases. That's the model at the Shirley Ryan Abilities Lab in Chicago, is that researchers are working alongside clinicians to produce their research. We know that educators are really an important role. Educators can be researchers, but they also play a huge role in teaching evidence-based practice to students. Clinicians are also, one of the most important roles, as they're the ones that need to be implementing the interventions. We know that clinicians that have a specific role in their job duty to be the evidence-based practice guide, so to speak, help the entire clinic improve their uptake of evidence-based practice. Students also have a role in helping translate evidence into practice. As they've been in school most recently, they've been in research articles. They have educators that their job is to teach them the most recent techniques. So students really can help practicing clinicians bridge the gap. But really, managers and administrators also play a role. Like I said, getting the equipment needed, giving time to learn these new techniques is important. And also policymakers play a role in evidence-based practice. Really, it's a system-wide approach.
Yeah, that's exactly the visual in my mind. It's like an infographic kind of connecting the dots. All right, well, let's switch gears and get specific. You're an educator yourself. So let's hone in your role, increasing the speed of translating evidence into practice. Obviously, we're doing this podcast because we think and we know that evidence-based practice is important, and we're trying to hurry up the delivery from bench to bedside, but we also want to not only be efficient and speedy, but make a difference. So with you specifically, let's do some case studies. What are you doing? What do we know? You're on the front lines. You're the first real touch point in Wisconsin at your place. What are you doing to speed up this translation of evidence into practice with your students from an education standpoint?
Yeah, so we're doing a couple of really cool things at my university. Number one, we offer a transitional program for OT assistants to become OTRs. And so we really can teach students that are already practicing clinicians best practices, and they're throughout the country. So that really helps spread this evidence throughout the country, and also emphasizes to clinicians already practicing the importance of evidence-based practice and how important it is to change when things have been updated. It doesn't mean that you were doing something wrong, but things get updated, and that's been really cool to see. I have students come back and say like, oh, I tried what you taught me this week in class and it really worked. Thanks. We are also have a pro bono clinic. So students spend time every semester in a clinic treating clients. And so they learn about evidence-based practice in their research classes. Then they learn about skills in their other classes, like I teach neuro rehab too. And so then they can take all of that they're learning in the classroom and try it out in the clinic. So it gives them that confidence to try these evidence-based interventions in a safe setting with professors and clinicians supervising them before they even get out into fieldwork and practice. And we also are really trying to teach our students evidence-based practice and how to apply that. I think we look at research studies and they say, do these interventions, but how do you do that in a clinic is sometimes takes a little bit of skill and training. So those are some things we're doing.
Yeah, that sounds fantastic, man. If I had to start over again, I would love to be going to Concordia. We did not have that. I went to a great school. Back then it was Duval College. Now it's Duval University in Buffalo. And that was one of the early entry-level master's programs in 1925. No, I'm just kidding. I'm not that old. I graduated in 1992 or excuse me, 1997. But we didn't have that pro bono clinic. That sounds phenomenal. So if you don't mind, just before we move on, because I have more questions, let's just digress for one more second on the pro bono clinic. How do for clinicians out there, teachers out there that might want to think about doing something similar, how does that actually get created and associated and affiliated with the OT college? And is that like really difficult to set up? And if you can spend a little bit of time on what's the management process for handling a pro bono clinic with your students and the patients and how that works? That seems really exciting.
Yeah, it is really exciting. Ours is an interdisciplinary clinic, so we offer OT, PT, and speech therapy services, and it has been many years in the making. Our clinic currently has a specific location on campus. We have, it's a full clinic. It looks like a clinic you would see in the community. It took a lot of design to make sure that we have a class that's specifically set up in each semester that has to do with that is focused on clinic. We have therapists who coordinate the clinic. So we send flyers out to local hospitals and local clinics to say that this clinic exists and get referrals from the community. A lot of our clients are people who either don't have insurance or insurance benefits have run out and they're still wishing to have more services. And so then students treat their clients for half of the semester, and then they switch between adult and pediatric. And then when they switch, another set of students jump in and treat those same clients or new clients, depending on client needs, for the other half of the semester. So it takes somebody to help us schedule, and it takes some good outreach with the community to make sure that we're getting clients. But as a faculty, we really feel like it helps our students. Our students have really reported increased confidence, and we've had a lot of, our students have really good feedback from fieldwork sites about how prepared they are.
That's amazing. So do you ever see patients without students there, or is it always with students?
It depends. We can see patients without students there. We are transitioning to a more focused on students being their role. And we've done group therapy, we've done individual therapy. And so, as new guidelines come out and as just resources change, we're making changes to the clinic, but our focus is always on providing best practice, serving our community, which is a value of Concordia, and, making sure that our students really are as best prepared as we can have them be.
I'm imagining most of the patients that are in the pro bono clinic are neuro, but you'd figure PT also. Do they ever, and OT, especially for hand therapy and PT with sports and ortho, do they bring in post-operative and orthopedic patients as well, or, for your ortho classes, or is it pretty much predominantly neuro diagnoses?
We predominantly see neurodiagnoses, but we do see orthopedic diagnoses also, and also some adults with congenital diagnoses also. So we don't limit what diagnoses we will see in our clinic. As a community, we just tend to find more people are seeking services that have had neurodiagnoses.
Yeah, so I think the pro bono clinic's really, really a smart move, not only for the students, but keeping the skills fresh for the educators. There's tons of barriers, right? So you kind of alluded to some. I was hoping you can put a finer point on a little bit more about the barriers in the classroom, specifically at schools. Just any other thoughts regarding what barriers exist to translating evidence into practice into the classroom? I'll express my opinion in a minute, but I want to get yours. Again, I thought of professors not maybe being up to date with the latest advances as one example, but if you could share your opinion about that.
Yeah, so there's a couple of things. A lot of educators are not still practicing clinicians. So it can be challenging to just stay up to date with what are the constraints of a clinic, what is changing in insurance, what is changing just in culture of practice when you're not a practicing clinician any longer. And that can really affect how we teach students how to implement evidence-based practice. And so we also, as educators, have our own biases from what we did when we were practicing clinicians. And so we really have to take the time as educators to be willing to modify our courses, stay up to date on evidence, and make sure that we're using the best resources that are the most up to date, and really modeling the importance of changing your practice when new evidence comes out to our students. For example, a lot of neurotherapists were NDT certified. Even when I was in school, that was a lot of what we learned about for interventions. And now guidelines have said that NDT is not the most effective treatment available for stroke, and that educators should really stop treating or teaching NDT in their classes. But when we open up some of our most common textbooks that have to do with adult rehab, all those neurodevelopmental techniques and sensory motor interventions are still a full chapter in our textbooks. So, right, so we are being told not to teach this. It's still in the textbooks. It is still happening in practice, but we really have to teach students that these are times and these are examples of when new evidence becomes available to really be evidence-based practitioners, that we really need to be okay with changing. It's not that some interventions like NDT are absolutely not effective. It's that interventions like task-specific training and mirror therapy and functional electrical stimulation are more effective, and we should be using those interventions instead.
Wow, yeah, you definitely hit the nail on the head. I mean, I graduated in the late 90s, where at the time, the teachers were thinking they were providing us with the best information possible. And for a lot of the reasons, that was correct because there was no evidence suggesting these other tasks. CIMT did not come out yet. FES wasn't really prevalent to that degree. We weren't doing mental practice and mirror box therapy. Dr. Ramachandran was doing it at that point. He created mirror box therapy, and he was doing it mostly studying that with the amputees at that point in pain and phantom limb pain. So all that stuff kind of evolved over time. And when we started SABO back in 2002, I remember doing courses on the SABO flex, which causes your fingers to flex, your spastic hand to flex to grip up a ball. Back then, most of the class was NDT trained individuals, and the thought of you squeezing a spastic hand would make them cringe. Of course, after the 2-day training, they got the science behind why that's okay. And in fact, strengthening a spastic muscle is not detrimental. It actually helps with recovery, and it's not going to increase spasticity. It can actually help reduce spasticity. But it was ingrained in them that these are things you must not do. And the sad part was when we were learning those things by our professors, there's no data to back it up. It was theoretical. Don't do X, Y, Z because just don't, right? It wasn't because there was a level 1 systematic review that's proven don't do X, Y, Z. So to your point, 17 years later, with how long it takes from bench to bedside, guess what? And this is what I'm going to get into in a little bit. I know you mentioned, you're still learning. Chapter 27 talks about NDT, but I'm starting to see a lot of therapists, new grads, know a lot of good stuff about evidence-based practice. I don't think it's all doom and gloom, but there's still an issue because we're battling new grads that are learning the latest with people like you at Concordia, but we're also on the other end of the spectrum dealing with therapists that are my age who have not even opened up one journal since their graduation where they still think Bobath and NDT is superior. So you have to wrestle both of those. And my 3 examples are, I did a LinkedIn post maybe a month or 2 ago on should we ban ADLs during the acute and subacute stage following stroke, because we all know from science that learn non-use is real, and it kills brain cells. If you avoid using your impaired side and you focus on your healthy side too much, you actually kill brain cells. And the problem is when the first 2, 3, 4 weeks post-stroke, if you only have 45 minutes with your patient, what are you doing that's actually going to promote neuroplasticity? Because you have that cortical sweet spot, that cerebral sweet spot from the late Alex Dromerick coined, is that's the time to boost neuroplasticity in those first few weeks. So the last thing you want to be doing is teaching compensation, teaching one-handed techniques, spending 45 minutes of the critical time on teaching them how to put a shirt on. Are ADLs important? 100%. If you're going to use ADLs, incorporate the impaired side to do the ADLs. But do not, by all means, do not avoid the impaired side and teaching them all hemi techniques, one-handed arm techniques during those critical 3-4 weeks. All you're doing is wasting the opportunity for neuroplasticity. Don't listen to me. Check out any journal article that talks about neuroplasticity post-stroke, spontaneous recovery. You can Google a lot of stuff on Umbra and pre-Umbra techniques. So there's a lot of things going on that talks about the recovery of the brain and brain healing with the penumbra, excuse me. So I probably got maybe 100 comments. I would say 95 of them were like thumbs up. That's great. I was really excited to see that. But man, there were some haters out there that still feel that if you have moderate to severe hemiparesis and you're 2 weeks post-stroke, absolutely you need to focus on ADLs, grooming, dressing, bathing, because there's a psychological component to patients. And my argument to that is, look, first of all, did you ask your patient, yes or no, do you want to focus on getting your shirt on, or would you like to get your hand back? Did you ask that question? Because I can guarantee you the patient's going to say, get my hand back, number one. Number two, you can learn ADL techniques at any time. There's no critical urgency as far as affecting recovery. But you can't get your arm and hand back if it's 7 months, 9 months, 2 years later. You missed the window. So focus on what matters the most, which is neuroplasticity. So there are still therapists out there that feel, no, there's a psychological component. No, we should focus on ADLs and occupation because that's what we do. And ignoring this neuroplastic window that's going to be detrimental for the rest of their life. Sorry for bloviating on that one. That was my first comment when I was reading through this podcast prep. My second one is I was a sports ortho guy before starting SABO. So I did a lot of, I got my training through the International Academy of Orthopedic Medicine. So I learned all about from neck down to hand. And I remember in my early days working with overhead athletes, a lot of my OT colleagues were afraid to touch the shoulder. They didn't know a lot about it. They didn't know the subacromial pathologies that cause impingement. They didn't know manual therapy techniques, what a posterior superior glide is. And yet the PT did. But what's odd was, so they didn't feel comfortable with the ortho shoulder, but if a stroke came in, they felt that they owned the neuro shoulder for stroke. So I was trying to true that up. Why do they feel comfortable that they can handle a stroke shoulder? But, and again, I'm overgeneralizing. Of course, there's therapists, OTs that are amazing at the shoulder in general. But yet for a huge population, OTs did not want to touch the subacromial impingement patient or the bursitis patient. That was weird. And then, and I'm going to come back to you to see, has times changed, at least at Concordia? And then my third thing I thought about was eSTEM. So forever, OTs, at least during my experiences and journeys early on, did not feel comfortable with electrical physical agents, did not feel comfortable with eSTEM, right? And I know in some states, OTs need to get certified, like in California and others, before, or so many hours. Yet our stroke guidelines say FES is really effective for helping arm and hand recovery. Well, if it's really effective, why are therapists still scared or uneducated when it comes to getting started immediately with eSTEM? Maybe times have changed. Maybe I'm completely outdated with this opinion. So those are my 3 hot buttons that I thought about for today. Is obviously the banning of ADLs, and then the reaction I got from that. It was I hit a nerve. And of course, I'm not saying ban ADLs. I'm saying if you're going to do hemi techniques and not incorporate the impaired side to do ADLs, we got to talk. Second one being what's going on with ortho shoulder as an example for students, OT, and students and new grads. And then the third, of course, being the FES. And, it's like when we think about evidence-based practice, and if you're studying in a school, an OT school, to learn about carpal tunnel, Colles fracture, tennis elbow, it's pretty darn easy. We're going to read articles. We're going to know what the latest protocol is, and we're going to implement. Well, what's the mystery with neuro? Why are we still debating over neuro guidelines when ortho is a slam dunk? So I'm going to pause. What say you?
Yeah, so there's a lot of questions there. Let's start with your first topic of ADLs and neuro recovery. AOTA and AJOT recently published new clinical practice guidelines for stroke. And one thing that they do mention in there is exactly what you said, is that, we have these different approaches that we can take. And that might be, do we try to remediate, kind of correct those impairments after a stroke, like shoulder subluxations and motor impairments? Or do we compensate? Do we take a more one-handed technique, learning to live with the deficits? And, one thing that they mention is that we shouldn't really change to that compensatory thought process until somebody's in the more subacute or chronic stages of stroke. And so, I think you bring up a good point of those teaching to compensate maybe would be better off later on, and trying to focus on remediating or teaching people how to best use their affected side when doing ADLs. It definitely does not need to be either my hand functions and I can use it normal, or it doesn't function normal and so I shouldn't use it at all. There is an in-between, right? People can use part of their arm to help hold something, to be a stabilizer as they're trying to open, even if maybe they don't have the dexterity to flip open a soda tab on their drink. So I think really thinking about how patients can best incorporate that arm will increase their independence, and really trying to kind of pair the two of improving our arm by doing functional activities and increasing our independence is really, really important. I think, that brings up other points of how do we get patients the most therapy possible to have that neuroplasticity, to really change how their brain is firing while they're in this stage of recovery. And I think we can do that by teaching them some of these interventions while they're in the clinic, while they're with therapists, and then having their family members help carry over things like mirror therapy and guided motor imagery or mental imagery outside of practice after they've already learned how to do it and have started to implement it. And I think the more we can come at therapy from all sides, and including the caregivers, including patients getting therapy outside of their traditional therapy times, is really how we're going to have the best outcomes possible.
Yeah, absolutely. So circling back to, the barriers with educators, how concerned should we be right now that, because I'm not connected to fieldwork coordinators, I'm no longer a fieldwork supervisor. I feel like the two people that matter the most for a student is the educator and then that fieldwork in the beginning and that fieldwork supervisor, right? I think about when I did my level 2 at an outpatient neuro clinic, I could have easily had a supervisor that embraced the compensatory model. And that would have been my thinking at that point, unless I did some independent research and realized, wait a minute, head scratcher moment, right? But thankfully, I had a wonderful supervisor who really was hardcore evidence-based, and that's why I embraced it and accelerated down that path. How concerned should we be right now in these OT schools that if we happen to, zoom in on any classroom with adult physical disabilities when they're teaching neuro, and they're still talking about, yeah, make sure you do a lot of these hemi techniques when they first get admitted to the hospital. Make sure you spend a lot of time on that functional independence, because we're not only battling the educators' delivery of education, but we're also battling the insurance company and the hospital administrators' urgent needs, which is get this patient as independent as soon as possible. So I know this is a different podcast where we can talk about, how the stroke patient, how to best care for a stroke survivor early on. That's not today's podcast, but it does make me a little concerned knowing that the educator's role is partly responsible for that problem. So am I overstating this, or does this still exist pretty significantly where OT school professors are still embracing this? Hey, when the neuro patient gets admitted, definitely work on some of these compensatory strategies. Or are you saying, guess what, guys, when the neuro patient gets admitted, you're going to spend 90% of your time on task-oriented arm training, augmented movement strategies, mental practice, mirror box, FES, and you're going to spend 10 minutes of your time on making sure they're independent in their room, teaching themselves how to get dressed. And a lot of it's video resources because you don't have all that time. And by watching these video resources, it's a DIY project at that point. It's going to teach you how to do all of your one-handed strategies because you know that the patient wants to focus on remedial approach of getting the arm and hand back. So am I overstating this? Should I be concerned? Are these OT professors really, really ignoring the compensatory model moving forward? Or are we still like 2001?
I hope we are doing better in education than that. I know when I started teaching all of our neuro classes, I really, really took an emphasis with students on following our clinical practice guidelines. You mentioned, should we be concerned if fieldwork educators maybe still aren't using evidence-based practice as much in their practice? Are we going to be teaching, are we going to have a problem getting students to take what we're teaching them in the classroom? As an educator, I am very direct with students, and I say that, in neuro, there are still times where it's taking longer to get practice to be using our best evidence strategies. And I give them strategies on how they can get clinical practice guidelines, the highest level of evidence available. And we practice, how can you teach your fieldwork educator that these guidelines exist, because a lot of clinicians don't necessarily know that the guidelines exist or that they can access some guidelines for free, that they're written in very clinician-friendly language. how can you advocate to be able to do these things while you're a student in fieldwork? And how do you encourage others, either as new clinicians or as students, to practice the guidelines and use these clinical practice guidelines? And I think students have given me feedback that it's really helpful to know where they might not see the highest levels of evidence being used in practice, so they can anticipate that before they go to fieldwork. And they also really appreciate when we kind of do a little bit of role play and practice in our labs of what that would look like. How would you professionally address that? I'd like to try this intervention, and this is the reason why. I'd like to try using FES or mirror box therapy in my session and see what the outcomes are. I know that in my class, I've taken a really strong role in trying to remove that barrier. But I do think that it is a barrier that is probably continues to exist, especially because the textbooks that are most commonly used in adult practice settings still include that outdated information. I think as educators, we can really strengthen our relationships with healthcare facilities in our area and really network with clinicians to make sure that we're doing best for our students, that we're understanding the challenges within clinics to help teach our students how to overcome those challenges to be able to provide best care. Because clinicians, I believe, really do want to learn and provide patients the best possible care. I love having lab assistants that are currently practicing clinicians. My lab assistants have all reported learning in my labs. So they're helping students, they're learning, but they're also reporting that they're learning new information because I'm including, practice guidelines from the last year or two when they get updated. So I'm really providing my students the absolute latest evidence and really having our students practice those evidence-based techniques in lab. And so they feel really comfortable once they get to the clinic being able to complete those interventions. I have my students practice using functional electrical stimulation multiple times in lab. That's one of the areas you expressed, your number 3 that wasn't happening a lot in practice. I have them practice learning it for doing shoulder subluxations and then also using it on the rest of their arm to be able to do things like grasp and release and, get triceps firing so that way they can reach forward. And then I have students do a lab exam. Like, I want you to be able to do these evidence-based interventions, and I want you to show me that you could do it in a clinic setting with time constraints and pick the most appropriate intervention for your client because, one intervention is not going to work across every single patient. We definitely need to pick our interventions based on our client presentation.
Yeah, no, that's a great summary of everything you're kind of doing from a clinical practice guideline standpoint. And by the way, for folks that don't know, where do you actually find the clinical practice guidelines? Where is that located? What do they need to be searching?
Yeah, so clinical practice guidelines, there's several of them for stroke. For a lot of our more common diagnoses, clinical practice guidelines exist. So in regards to stroke, the American Occupational Therapy Association does provide clinical practice guidelines that are available in AJOT. To get access to that, you need to be an AOTA member. But if
you're not an AOTA member, you're not going to be able to provide the best possible care for your patients?
Well, and so...
How else can you find it?
Yeah, so...
Not that I won't want to be an AOTA member, I just feel like that should be open access just for the betterment of the people.
I wish that it was open access for all OTs to access their guidelines. Because it is not, I also realize that when my students leave, they are going to go to practice and they might not have access. And so I always try to give them some free resources. So the American Heart Association has stroke guidelines. The ones specific to rehab were last updated in 2016, which is starting to be a little bit old in terms of the evidence. So I hope that becomes updated soon. But those are free and they are detailed. They also have an app that gives a little bit more of an overview. It doesn't go as in depth, but it does give you easy to access information when you're in the clinic. But I teach my students right now currently that the two, best free ways to get clinical practice guidelines are through Canada. They have the Canadian Stroke Best Practices. I really like that resource. It gives a lot of detail and a lot of reasons behind why they made their recommendations. And then NICE, which comes out of the United Kingdom and Ireland, has the National Clinical Guidelines for Stroke. And those were updated in 2023 as well. NICE also they really consider like financial constraints of clinics when they make their guidelines. So that can be a little bit different because their healthcare system is different than our country. But in general, when it comes to what interventions are good, what should we be doing, I think the Canadian Stroke Best Practices and the National Clinical Guidelines for Stroke are really good places for clinicians to find their clinical practice guidelines for free. And remember, clinical practice guidelines are statements and recommendations intended to optimize patient care. So they are written in clinician-friendly language. They look at systematic reviews of evidence, and then they really assess the benefits and harms of alternative care options. So they take all this complex scientific information and make recommendations that are easy to understand for clinicians. So they rate the quality of the actual evidence of the research, and then they also rate how confident they are in making the recommendations, which is good. Sometimes we don't have either the strongest evidence or to support an intervention, but if it's not going to harm your patient, they'll say hey, this is worth a try. And so I think knowing both the level of evidence available and how confident they are with the recommendations is really important for therapists to be able to make judgments and determine what is going to be best for the patient directly in front of them.
Yeah, that reminds me of EBRSR out of Canada, the evidence-based review. I think it's for stroke rehab. I think it's doc.org, if I'm not mistaken. It's either .org or .com. They go over all of the stroke guidelines. Been doing it. They're on their 21st edition or something like that. It's been since the early 2000s with Dr. Robert Teasel. And him and his team will break it down into the evidence's interventions are either beneficial, mixed or inconclusive, or not beneficial. So, and it goes over the algorithm and the percentages of what the results need to show, what percentage of outcomes were positive in order to be considered beneficial, mixed, or not beneficial. So I really like Dr. Teasel's summaries as well. I guess where it gets a little concerning is when you think about the clinical practice guidelines, and you think about, are we looking at, is it function related, or is it going to be motor improvement, motor recovery related? So part of me also just gets slightly frustrated with our profession and reimbursement with the fact that patients that suffer a chronic problem, such as for most stroke, which is going to be a lifelong problem for many, you're not going to automatically, it's not like a rotator cuff repair where in 6 weeks you're going to achieve this. So when you do your functional goals, long and short, sometimes they're still unachievable. And remember, most stroke patients, or if not all, want to go back to baseline. They want it the day before their stroke, that's who they want to be. So if I say to Mr. Jones, well, look, I know your ultimate goal is to play the piano, because he did, not because he wants to try something new. And in order to do that, you need to have some shoulder flexion, elbow extension, wrist extension, and maybe some isolated fingers to start for short-term goal. A lot of times you can't even achieve the short-term goal. So what I like to, and then you get Mr. Jones being non-compliant, depressed, bummed out, and no longer motivated. I would. So I like to start with micro goals, which are not even taught in school. Hopefully it's just human nature to have micro goals, which, and I know they're not reimbursable, but Mr. Jones, I just want a twitch of your thumb or a flicker of your deltoid within the next 2 weeks. That's all I'm looking for. And then if he can see that micro goal, he's still motivated. He's still bought in. He's still bought in. He's a believer still. But if we have to do these stupid short-term goals because of insurance or what we were taught in school, and all we're doing is setting them up for failure, that's like a psychological, downhill battle, right? You're playing chicken with your patient's mind. And so what are the clinical guidelines? Are they agreeing with that approach, or are they also saying, look, as an OT, I know any type of clinician, everyone knows the end result's always going to be function because that's what life is. But do the clinical guidelines actually talk about, you're not going to get function right away, so let's use these motor assessment, high quality, objective, standardized tests as the true Bible of results until function happens? Or are we still thinking, all this is pointless unless this person can do this with ADLs?
So I guess it depends what clinical practice guidelines you're looking at. So the previous AOTA guidelines did focus on like Fugl-Meyer's and other impairment-based outcomes and looked at interventions that were effective for that. In the 2013 guidelines, the outcomes that they looked at were ADL, IADL, social participation, and caregiver outcomes. And so they did not look at or did not include systematic reviews that were based on impairment. Instead, they based them on the ADL outcomes. And yes, you're right. ADL outcomes and IADL outcomes are super important because we want people to be able to function at their highest level. We know that stroke can cause significant disability and, have a lot more caregiver needs. But you nailed it on the head. We can't forget those small, more easily achievable, measurable goals of improving impairments, improving their motor function before we get to that, ultimate ADL, IADL goal. In other countries, in Canada and the UK, they are definitely still including the impairment outcome measures in their practice guidelines. Canada even gives recommendations for different assessment tools in their guidelines, and things like Fugl-Meyer and Wolf Motor and those more traditional motor assessments are in their assessment tool recommendation list. AOTA's practice guidelines don't give specific recommendations for outcomes or outcome measures. They have some case studies where they use outcome measures, but they don't say we recommend these outcome measures.
So let me guess, I can probably, it's safe to assume you do with your students, go through kind of like Canada and the UK. Which ones do you typically, for stroke, which ones do you typically promote or recommend for other listeners to consider if they're not doing?
Yeah, so in my class, we teach Fugl-Meyer assessment, which is the gold standard for upper extremity motor recovery measurement. It definitely is going to be more sensitive and pick up on change quicker than ADL assessments. And I have my students do a lab exam where they have to show me that they can do part of the Fugl-Meyer assessment and accurately report it. And I think I really would love to see more clinicians using these gold standard upper extremity assessments. The scoring sheet, I think, looks overwhelming to therapists, but it really is a pretty easy to do and quick test. So I am teaching students that one. And then the stroke impact scale is a patient-reported outcome measure. And I think it's really important that we always include what our patients are feeling about how their recovery is going. And it's also another, it's easier to get that data. It doesn't take as much time when patients are the ones that are completing the measures. They can complete it in the waiting room if you're an outpatient before your session starts. So that way we can spend as much time doing hands-on assessment as possible. So yeah, I really do still think that there is benefit in, measuring arm function and not just ADLs.
Yeah. I know we're almost done here for today, and it's been obviously an eye-opening, fun, of course, conversation. And I'm a big fan of free resources and free interventions and free education. We talked pre-show about ViaTherapy App. We'll get into that in a second. As you may or may not know, Steve Wolf, a dear friend of mine who's on our scientific advisory board since 2004, he is one of the authors of ViaTherapy when it first came out. Why don't you spend a few seconds talking about ViaTherapy, because it goes back to exactly everything we just mentioned. And then I'll end with one comment regarding another free resource. But go ahead with ViaTherapy.
Yeah, so it is a app that is free, and it looks at recovery interventions for patients with upper extremity stroke rehab needs. And it really gives a clinical decision tree. So it helps therapists determine what are the best interventions, how much, how long, what does that intervention actually look like, with videos based on how much movement a patient has, based on if they have shoulder pain or not, and also how much time has passed since they had their stroke. And then it also gives recommendations of different assessment measures to use to determine if patients are making progress with that intervention. And it's so user-friendly. And so I have my students all download this app. I suggest clinicians download it. It's easy to use in the clinic, and it really helps you pick the right intervention for the right patient. Taking scientific research and determining inclusion and exclusion criteria is much more challenging than using this app where you click a button when it says, yes, they have no shoulder pain or no, and really helps you pick the best. I love it. Download it. It is great.
Yeah, I agree as well. Another one that actually, you may be familiar with the GRASP program. Are you familiar with them out of the University of British Columbia, Janice Ang?
Yeah, I actually met her at the ACRM conference this year. It is a great program, and it's free, and the pictures are great. The handouts are great.
Yeah, I like that one a lot too. GRASP program. I made a note here. It is Graded Repetitive Arms Supplementary Program out of University of British Columbia. Janice is a PT and an OT. So check that one out as well. My final comment is, I think when it comes to translating evidence into practice and going from, the research to clinical use, it's kind of like the 80-20 rule for me. I think that it doesn't necessarily have to be 17 years. I think if it was neuro nerds, if you will, diehard neuro nerds that really embrace the evidence, if something was, a level 1 article came out tomorrow saying that great news, we can improve wrist and finger extension by doing this specific protocol, I would say the neuro nerds, the 20% would that would be a 1-year turnaround time, if that, right? So I wonder why it's 17%. I think it's just because in general, 80% of, people are not going to be specializing in that niche. So they're going to be slow to uptake this information because they're going to have to wait for that circumstance, wait for that supervisor, wait to challenge it or question it or try it, because they're just not knowledgeable because they haven't been focused on it. Otherwise, I would love to see a study done. If you happen to be in that niche category, that vertical, how long is bench to bedside at that point? Because you would think it'd be less than a year.
Yeah.
But I think overall, it's 17 years because not everyone does their own thing and they're specializing in different areas. So that's my 2 cents. What are your final thoughts regarding hope for the future? Obviously, Concordia is blessed to have you. Students are blessed to have you. Clearly, they're prepared when they leave you. So congratulations for everything you're doing. What are your final thoughts in general for the OT schools, students that are listening, educators that are listening? How are we looking for the next 5-10 years?
I think my biggest takeaway is use clinical practice guidelines. I'm not even sure how much they're being used as like the primary intervention resource in schools or in practice. I think that people are talking about this. People want to be better. So I really have good hope for the future, but I really hope we see more people investing in clinical practice guidelines and teaching them, and clinicians looking at them and using those free resources that are available. Free takes away a barrier for us not being able to do clinical practice guidelines. And, free intervention resources are good too.
Yeah, 100%. And I think, it's not like it's end all be all. It has to be evidence-based or don't use it at all. Although that seems to be logical thought. because there's going to be some arguments, like you said, not saying eliminate NDT altogether. There's some benefits to doing NDT. I think the new lunch series that needs to take place of hospitals, and definitely maybe conversations with the teachers and students, are anything that comes out of your mouth or anything you want to do or any chapter in any book, challenge it, support it, and bring to me level 1 evidence. But it doesn't have to be level 1, but really good evidence that says we should spend the time continuing to discuss this topic. I think we should question everything that's in our OT textbooks because clearly you're bringing up chapters that shouldn't be in there at this point. Not saying ignore it altogether, but it should definitely not be a chapter, and it should definitely not be highlighted as that could be like an appendix. Other things to consider that should be ancillary to your key interventions, right? It should not be considered a key intervention if the evidence doesn't suggest it's beneficial. So I think the next challenge for the next 10 years is professors saying to students, or someone challenging the educators as well as therapists to the supervisor, whatever you're doing in your 45-minute session, bring a journal article on why you thought you should do that and what the evidence says about what you just did. And if you can't back that up with an article that's peer reviewed, eliminate that from your intervention toolbox, right?
Absolutely.
Yeah. Well, listen, this has been a phenomenal 1 hour. Thank you so much for your time today, Jessica. I hope the audience has learned something new. I know I have. And don't be a stranger, and looking forward to having these discussions again in the future.
Hey, thanks for having me today.
Thank you. You have a great day.
You too.
Thank you for tuning in to the No Plateau Podcast. Please make sure to like and subscribe to stay up to date on more stroke and brain injury recovery stories. The No Plateau Podcast is intended to give you an insight into stroke and brain injury survivors' journeys. Any opinions given on this podcast are strictly the individual's, and we do not suggest that you necessarily hold the same viewpoints as anyone on this podcast. This podcast is intended to supplement stroke and brain injury survivors' recovery journey. Therefore, all content affiliated with this podcast is for informational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health providers with any questions you may have regarding a medical condition. Reliance on any information provided by the No Plateau Podcast is solely at your own risk.